So I'm gonna speak about some objectives here about common metabolic disturbances and just what to look in the exam, how to treat and manage, and the approach of some metabolic disturbances. Okay, so just want to explain first why this lecture is important. It's not, so it is important not because Satya gave me this lecture, although I like Satya so much, he's like one of the best fellow I've ever worked with in all the conference. But it's also because like I made such an effort looking through different articles, different books, and like I was trying to simplify from different resources, and yeah, so I was trying to make it as simple and straightforward as possible. So the third reason, also kids, when they present to the emergency, they usually present with non-specific presentation. Yeah, so any presentation of a kid, it can be a chief complaint. Like for example, high-pitched crying is a complaint. So also shaky baby is a presentation as well. And also decreased responsiveness is a presentation of a disease as well. So let's start with case one. Okay, so I'm gonna start with our model baby here. Okay, so this is a newborn, but usually newborn, they don't do that. It's just to show you this is a kid, it's not just me. So newborn was brought by his mom due to jitteriness and decreased activity. So as you see here, it's like non-specific presentation. So no history of fever, recent illness. He's like feeding formula. He wakes up more frequently at night for feeding. And so during taking the pregnancy and perinatal history, the mom had gestational diabetes and the baby was born large. So what makes you think when you see like gestational diabetes and large gestational age? So what's the first thing to think about here? In a baby who came like jitteriness, decreased activity? Yeah, correct. So vital signs, tachycardia, patient looks tired. It can be like hypotonia, it can be like completely normal exam. So sometimes you need to depend on yourself, like you cannot look for Satya every time, maybe he's just busy doing some private stuff. So what's the first test you want to do for this baby?
Finger stick.
Exactly, finger stick. So finger stick is glucose is 20. This is just useless effect. So let's bring up the, I'm going to speak just briefly about hypoglycemia. So I was looking through definitions from different sources. So the most common definition I found is this, which is plasma glucose below 45 in asymptomatic child and below 35 in asymptomatic newborn. So what's the that's cool. So pathophysiology. So usually so it depends on glucose utilization versus production. So usually it's mediated by like those hormones, like insulin for the utilization and the counter-regulative hormones for the glucose production. So if you go through the causes here, for example, inadequate intake. If you have a newborn who's, for example, getting breastfeeding and the mom's not producing enough milk, so the baby might get hypoglycemic, but that's usually correct with just feeding. Other causes also like excess insulin, like for example in this case, like large gestational, like large baby, they usually get with hyperinsulinemia, and they get hypoglycemic. Growth hormone or adrenal hormone deficiencies. fatty acid oxidation disorder, carbohydrate, or infection. I don't want to lose you distracted, so your attention, that's why. Small gestation age is also because of inadequate storage. So usually in the history you ask about, for example, everything in the history. So like patients, they present like sepsis-like picture. You're gonna ask about infections, but there are like some detailed history you need to take. So maybe you don't think about it first, which is you can ask about the feeding of the baby, any family history of any congenital diseases, perinatal history and pregnancy complications, and also the sepsis history. Physical exam is also not specific, so basically you're going to do head to toe exam. And so you need to look for weights at the presentation and weights when doing delivery. Also examine cardiac respiratory because one of the differentials is also congenital heart disease. You're going to look for other causes. The baby has vomiting, like atresia, volvulus, paroxysmal, or antiception. Also, you need to check the GU for ambiguous genitalia for congenital adrenal hyperplasia. So, as in this case, the first thing we did is finger prick. We're still going to do the sepsis labs, but in addition, there are special tests that you need to do with the first blood work. But that doesn't mean you delay the treatment for hypoglycemia. Like for example, if you have a patient who's not stable and not responsive, so you're gonna treat first. You can just delay the special test maybe after the admission when the baby is more stable. But they are the serum insulin, C-peptide, growth hormone, glucagon, and cortisol, which are the hormones that mediated the glucose utilization and production. So also urine ketones is helpful to narrow the differential diagnosis. So if you have positive ketones, so it's most likely going to be from ketotic hypoglycemia, adrenal or growth hormone deficiencies, and other inborn error of metabolism. If you have negatives, it could be from the insulin or fatty acid oxidation defects. So there's also one additional thing, which is glucagon. So usually we give dextrose immediately, but glucagon could be therapeutic and diagnostic at the same time, depending on the case. So for example, if you have hypoglycemia that's corrected after you give glucagon, that means the baby has enough glucose storage, but they don't have enough hormones to produce the glucose. So you're going to think more of hormonal deficiencies. But if you give glucagon and still the baby is hypoglycemic, most likely the baby has not enough glucose storage. So this is basically what I just mentioned right now. Just to simplify, if anybody needs this, So the treatment for hypoglycemia. So just to make it simpler than this, so basically you want to give the whole D50 to inside the vessel, but the smaller the vessel, the more chance to get the vascular injury. So for example, if you think of newborns like vending machine that only accept 10 cents, you want to insert like 50 cents, like how many 10 cents you're going to insert? Like 5, right? So it's going to be 5 ml per kg. The same thing with infants and toddlers. If you think it just accept 25, you're going to give like 2 ml per kg. And like adolescents, you're going to treat like adults. So after the bolus dextrose, you're going to give maintenance. So you can give 6 to 8 milligram per kg per minute of T10. And I mentioned here antibiotics because when the baby presents with this picture, like sepsis-like, decreased responsiveness, so you still have like sepsis infection differential. So you need to treat empirically with antibiotic. And we have here options of Amgen or cefotaxime for newborn less than 2 months and ceftriaxone for older infants. So you do the dispo for the patient. So this patient required resuscitation, required the glucose and maintenance, and also needs special tests, we need to figure out the diagnosis. So usually the baby is going to get admitted, but if they present with more critically ill baby and require more resuscitation, more fluid, so usually this baby goes to the ICU. So I'm going to go to case 2. Just change the subject. Let's go back to our model baby. That is more creepy. Okay, this is the one. Okay, so it's basically the same presentation. Newborn brought by mom, determines decreased activity, but more of decreased responsiveness. Also, like the same story here. So the difference in vital sign in this baby, that the baby here is in shock. He's tachycardic, hypotensive, and so exam-wise, also the baby is like lethargic, is not responsive, and hypertonic. So during the GU examination, you notice there's clitoromegaly. So what you going to think about here in this case? Congenital adrenal hyperplasia. So it's from the name, congenital, adrenal glands, and hyperplasia. So adrenal glands is corticosteroid and sex hormones. So usually the corticosteroids deals with salt, blood sugar levels, blood pressures, immune system, and the sex hormone deals with the puberty. So this is just a brief about how it works here. So if you have low corticosteroid level, the pituitary glands secrete ACTH to stimulate the adrenal glands to produce the steroid precursors. So in normal person, usually steroid precursors is going to go and produce corticosteroids and sex hormones. But in a patient who has a deficiency in one of the enzymes that cause congenital adrenal hyperplasia that I'm going to mention, so they cannot produce corticosteroid, so you're going to get more secretion of ACTH, and ACTH is also cause skin hyperpigmentation, so they're going to get hyperpigmentation from that, and they're going to build up more steroid precursors that's going to go and synthesize more of sex hormones because they cannot produce corticosteroids. So the end result, you're going to get more sex hormone than corticosteroids. So we have, in CAH, we have different enzymes deficiency, but the most common enzyme deficiency is 21 hydroxylase. So it accounts for about 95% of cases of CAH. So if you see I'm not going to talk about all this. Just if you see the 21 hydroxylase, so if you don't have this enzyme, you will not be able to produce aldosterone and cortisol. So most of the steroid precursors are going to go and produce testosterone. So this is more of like exam purposes than clinically. So you can know by the presentation from blood pressure and virilization like what type of enzyme deficiency. So if we take just the first letters from each enzyme name, and so the first letter, the one on the left side, let's say it's for the blood pressure, and the number on the right is for virilization. So every number 1, that means increase, and every not number 1, that means decrease. So for example here, 21 hydroxylase, so if the blood pressure is going to decrease, so the baby is going to present with hypotension. And 17 alpha hydroxylase, so if you see we have number 1, that means decreased blood pressure, so usually they present with hypertension. in 11 beta hydroxylase is also the same thing. So every number 1, that means increase. So in virilization, it's also the same thing. So if you have number 1, that means increase. So I made it here looks like male genitalia just to get stuck into your mind. That means virilization. So this is how it's stuck into my mind. That means virilization. So every number 1 looks like this. So usually in 17 alpha hydroxylase, you don't see virilization in baby girls. 11 beta hydroxylase also you're gonna see virilization.
That's awesome.
That's also like example. So in the history, usually babies, they present at the age of about 2 weeks with acute presentation of shock. Also, they present with non-specific features, or like lethargy, irritability, poor feeding. Physical exam is also the same thing. So vital sign is very important because they present with shock. And also you're going to do complete head to toe. So GU exam is also very important. It helps with the diagnosis. In females, you're going to get the clitoromegaly, fusion of labia. In males, it's most commonly it's going to be normal genitalia, but they also might present with small phallus or hyperspadias. Also, as I said before, hyperpigmentation because of the excess of the ACTH production. So this picture of clitoromegaly. So also diagnosed as bedside glucose first because they also can present with hypoglycemia. Also they present with other metabolic disturbances like hyponatremia, hyperkalemia. I don't know if somebody was on CCT about like 3 days ago. There was an adult patient who presented with the same picture of hyponatremia, hyperkalemia, and hypoglycemia. She has adrenal insufficiency. So it's not that rare, even in adults you might see it like one day. So although they present with hyperkalemia of 6 and above, but usually they don't come with ECG changes. But you need to get the EKG just because if there is any changes, you're going to treat it that's first, and also it's going to help with the dispo. Check in this steroid profile as an inpatient. So treatment is also resuscitation, fluid resuscitation, IV or IO, normal setting. You're going to treat hypoglycemia with the same that I mentioned before in the hypoglycemia section. Also, this is very important is to give hydrocortisone if you suspect CAH. We're going to treat hyperkalemia EKG changes with IV calcium gluconate, and but do not treat hyperglycemia with insulin and glucose because they usually present with hypoglycemia, and if you give insulin, you might aggravate their hypoglycemia, and we are trying to correct that. The dispo is also admission because patients present with shock and we did like fluid resuscitation. But if they present with like severe hyperkalemia with EKG changes, so that needs ICU and endocrinology consultation. Okay. So now I'm going to talk briefly. So this is the last subject. So I'm going to talk briefly about inborn error of metabolism. And it is important because, as I said at the beginning, they present with non-specific feature. So they present like sepsis. We usually don't think about it. We just order like sepsis labs, but there are some specific labs that can help in the diagnosis and management in inborn error of metabolism. So in addition to all the history that we asked in the previous 2 cases, also you should ask if the baby has any known disease or any known disease in the family. If there's any acute illness with fever that might aggravate a hidden inborn error of metabolism. there's any change in diet, for example, excess protein in the diet. If there's like food craving, the babies like wake up more often during the night for feeding. That's maybe because of he's getting hypoglycemia. So the assessment is ABC. Breathing, like usually tachypneic, they are dehydrated. So when do you suspect inborn error? If there's a baby who comes with like tachycardic and jaundice, or having any organomegaly like hepatomegaly, splenomegaly, or both, or they have unusual odor like ketone odors, sweaty feet, or maple syrup. So if you have a baby like this and looks septic, so you're still gonna order septic lab, but adding ammonia is helpful as well. So you're gonna add ammonia and urine ketones. So sepsis, they come with, like, for example, metabolic acidosis, but usually they don't present with hyperammonemia unless they have like fulminant hepatic failure, for example. So if they have like high ammonia, you're gonna order like other tests, but that's usually like inpatient, not in the emergency. So this is just an algorithm of approach of inborn error. So the management, I was reading about this subject. There's something called metabolic on-call service. I'm not sure if we have this. Dr. Khan?
We do not.
We do not have this? Okay. Maybe in other hospitals we're going to call the metabolic on-call service. Also, you're going to do the IV resuscitation, you're going to correct the metabolic disturbances, treat their presentation, they are presenting with seizure, and also hemofiltration, which is basically the CVPH. So that's if they usually have ammonia more than 500. If you have ammonia still high but less than 500, you try to eliminate the ammonia by giving some medications, like for example, sodium phenyl acetate and sodium benzoate to try to eliminate the ammonia. And also you add arginine, either with the sodium or even without it, just to try to prevent going into the hemofiltration. So I think that's going to be the last slide that I have here. If you have any questions about the subject. Okay.